I want to start with a question that did you know that patient wait times in the United States 50% have increased over the last 2 decades? 50% is significant, right? So it was, I think, around 2 weeks, and it's right now 21 days for the overall patient wait time. We constantly see headlines about long patient wait times and their detrimental consequences on patient health. For example, in the United States, we've seen that doctor wait times average 1 month in particular area of the specialties. In Canada, the situation is even worse. There are long wait times for healthcare hit Canadians in their pocketbooks. And also, it's pretty much the same in the United Kingdom, where new data shows that cancer treatment, for example, waiting times have increased nearly for half of their National Health Service areas this year. So this is a global problem, and particularly reducing patient wait time could improve patients' outcome, could improve patient satisfaction, patient adherence, and it has a lot of positive impact on both patients and our health systems. So in this work, I'll be actually talking about an intelligent appointment scheduling approach for hematology and oncology treatment centers, which is entitled Dynamic Distributed Ambulatory Care Scheduling. This is a joint work with my PhD supervisors, Dr. Ostork and Dr. Patrick from the University of Ottawa. Okay, I also introduced myself earlier. I'm Amirhossein Moosavi. I'm a Michigan Data Science Fellow from the University of Michigan. So I actually jump into the presentation because I don't want to take a lot of your time. So let's go through the problem description and let's consider a hematology and oncology center that provides treatment to cancerous patients across multiple campuses. We assume that the campuses, they do not have overtime. Basically, they have to treat all of the patients within their regular opening hours. And also, we assume that all of the campuses of that center are capable of providing services to benign tumors. But when it comes to malignant tumors, each of the centers is specialized in a specific group of malignant tumors. You may ask me what's the difference between benign and malignant tumors. So benign tumors are those cancerous tumors that they do not typically spread over different parts of the body. But malignant tumors, which are actually much more dangerous, is those that they tend to spread over different parts of the body. For this problem, we're assuming that the arrival or the referrals of the patient may either require one appointment or they may require multiple appointments. And when they require multiple appointments, we assume that once we schedule their first appointment, we have to schedule all of their follow-up or subsequent appointments as well. Each patient is allocated or is associated with a treatment type and a priority level. Treatment type essentially defines what type of treatment they require, and priority level defines the urgency of their treatment, like how fast we have to treat that patient. Depending on the priority level of the patients, we specify two different thresholds for each of the patients. The first one is the wait time threshold, which is basically a threshold. If the hospital is able to schedule prior to that threshold, everything is fine. But if they're unable to schedule the patient before the wait time threshold, they have to pay a penalty for keeping the patients on the wait list for each single day the patient will remain on the wait list. There's also a second threshold called deferral threshold. And this is effectively pretty much the same. However, it basically says how long the hospital can keep the patients on the wait list. And there is actually a hard threshold for this one. If the hospital is unable to treat, if the hospital is unable to schedule the patient prior to that threshold, they have to transfer the patient to another center, right? So the first one penalizes for the wait time. The second one would determine a period of time where the hospital can keep the patients on the wait list. If they're unable to schedule them, there is actually a big penalty of transferring the patients to another center. In terms of uncertainties, we consider two different types of uncertainties in this particular problem. First of all, we do not have full information about how many patients of different classes, different treatment types, and different priority levels would arrive every single day, right? So that will be uncertain, and it's actually one of the aspects that contributes to the dynamicity of this problem. And the second one is that we also assume the patients might use emergency department, and that effectively depends on how much we keep the patients on the wait list. The longer they wait on the wait list, the more they tend to use the emergency department because like not being able to receive the treatment, it may result in deteriorating their health condition, and effectively it can result in utilizing the emergency department, which is, by the way, one of the costliest resources in the hospital. Okay, so let me go back and try to explain a little bit further what initially motivated us to investigate this problem. Everything goes back to summer 2023, where I've been mentoring a master's student at the University of Ottawa. She started an internship at Ottawa Hospital, which is actually the largest hospital in Canada's capital. And she's been working with their medical vicar unit, which provides hematology oncology treatment. Through our collaboration, we learned that they're using fixed scheduling templates in order to schedule patients. You can see something similar on the right-hand side of this slide. So you have fixed allocation of time slides for each of different treatment types. And once a patient arrives, the booking clerk is responsible to allocate those arrivals or those referrals to the empty available spots of their corresponding treatment types. In our collaboration, we learned that they are using a 15-year-old scheduling template. This is like too old, right? The mix of the patient have changed over the years, their demand have changed, and we also learned that scheduling template, that old scheduling template, was built based on trial and error, right? Someone was like trying to create something by hand, manually. So it wasn't optimized. So we were kind of pretty sure through optimization, we could actually update that scheduling template. So for that reason, we started analyzing the data, and also we created a mathematical model. And by the way, you don't need to read the mathematical formulation right there. But as a result of that, all of the efforts we did through that internship, we created and we updated the scheduling templates. According to our analysis, we realized that utilizing the scheduling templates across all of the campuses of our partner hospital, they could increase patient throughput by 7 patients every single week. And they could also improve their resource utilization by 10%. Our partner hospital was quite happy with this, and we were also happy with this as well. However, we were not entirely happy. We thought that there might be some limitation associated with this approach, and we could potentially improve it. So the key limitation with scheduling template is that they're actually determining fixed allocation of different time spots during a planning horizon of 1 week or 2 weeks. However, this problem is dynamic. 1 week we might have more of one specific group of patients. In another week, we might have more of another group of patients, right? So this like the wait list of the patients dynamically changes over time. And having a fixed scheduling template might not be the ideal approach, or might not be the ideal decision-making support for scheduling the patients. So for that reason, we decided to create a dynamic approach that particularly is infinite horizon. It's not a finite horizon, because like scheduling problems are inherently infinite horizon. What does that mean? That basically means every single decision that we make today has an impact in the future, right? So a finite horizon approach, like scheduling templates, might not be superior. So for that reason, we started by formulating a dynamic program algorithm. So let's actually dive into this, see what is actually the primary components of our dynamic programming algorithm. I do not go into much detail. I keep it into basically like the primary things. If you have any questions, just let me know. So I'll first start by decision epochs. Like the way booking clerks makes decisions, we assume that decision epochs occur every single day, which effectively means we are going to make scheduling decisions every single day, right? We also consider a decision horizon, a T-day decision horizon. This is a period of time where we could start the first appointment of each of the referrals, right? So, for example, let's consider a 7-day decision horizon. Depending on how many patients we have on the wait list, we could actually start scheduling some of them. However, we extend that decision horizon to a T prime day planning horizon. This is a little bit different, right? This planning horizon is much longer than the decision horizon, and effectively we extended that much that we could make sure all of the follow-up appointments of the patients on the wait list can be scheduled within the planning horizon. So effectively, this decision horizon is there for first appointment, where the first appointment can happen, but this planning horizon is actually extended that much that we could capture all of their follow-up appointments. For example, if a patient requires 4 weekly appointments, and if we started, for example, today, we have to extend the planning horizon at least to 29th of February, right? Today is 29th of January. They require 4 weekly appointment. We are starting it today. We have to extend it that much so we could make sure that all of the follow-up appointments can be captured throughout the planning horizon as well. All right, so that was with the decision and planning horizon, and now let's turn into how we could make sure that we are capturing the current status of the system. And we will do that through defining 2 primary state variables, right? So to capture the current status of the system, we have to make sure how many patients are on the wait list, and we have to also calculate how much of current capacity we have utilized. For the waitlist, we define a matrix like this, where we have we are actually showing different types of patients with different priorities and with different number of appointments, and how many days they have waited on the wait list. So effectively, these are non-negative integer values that specify the number of patients from a specific type, specific priority, how many number of appointments they require, and how many wait times on the wait list, right? The second component is for the current schedule. So we have to make sure how many capacity we have utilized. So effectively, we can plan for the future patients, right? We have limited capacity. We have to keep track of that as well. So again, we have a non-negative integer variable where we're actually capturing the number of patients from a specific type allocated to a specific campus on a specific day. Okay? So we have a state variable for the wait list, and we also have a state variable for the current schedule. And the primary decision that we make, depending on the wait list that we have, how many patients we're going to allocate to each campus on a given day from a specific type, right? So that's actually the primary decisions that we have to make on every single decision epoch. All right. Do you have any questions for me? Anything that you want to ask before I continue? I consider it as a no, so then let's continue. So, like any optimization problem, we have to make sure that the decisions we make are feasible, right? They have to be practical. So the first thing is we are going to restrict the number of patients scheduled for the first appointment to the number of patients we have on the wait list. Effectively, we cannot schedule more patients that we have on the wait list. That seems quite obvious. We also have to make sure that the follow-up appointments of the patients are scheduled on time. It has not been delayed or it has not been scheduled earlier. It has to be allocated to an appropriate campus, which is actually specialized and equipped to provide that service. As soon as we schedule their first appointment, right? So like I said earlier, once first is scheduled, the follow-up appointments must follow as well. And the last constraints, or the last feasibility constraints that we have, is that we have to make sure that there exists a feasible patient schedule that has no overtime and that also respects the limited number of beds and nurses available in the centers, right? So respecting the last constraints was the most difficult part of this problem. I'm going to actually explain it a little bit later because, I mean, briefly, if I want to say it right now, is that it requires us to utilize binary variables, right? So that's actually the primary thing, which results in a lot of computational complexities. Well, anyway, going into the objective functions, what are we trying to optimize in this problem? First of all, we want to make sure that we are minimizing the patient wait time and deferral costs, right? We're scheduling the patients as soon as possible. We also would like to make sure that we're minimizing the emergency department utilization penalty. So the less we utilize the emergency department, the better it is for the health center. And also we have to make sure that the patient transfer penalty is minimized. That effectively has the highest that has the highest penalty among all of the objective function components. And that's primarily because we want to discourage the model from transferring patients to another hospitals, which is actually a big inconvenience for the patients. All right, so like I said, modeling the last component, the last feasibility constraint was a little bit computationally, was a little bit challenging for us and resulted in a lot of computational infeasibilities. For that reason, like any dynamic program that actually suffers from course of dimensionality, we develop a linear programming-based approximate dynamic program algorithm. We do that in three primary steps. I'm not going to go into details for that. But again, we still need to improve this state-of-the-art approximate dynamic programming algorithm. And that primarily relates back to the third feasibility constraints I mentioned earlier to you, because it requires binary variables to model limited resource availability. The subproblem in the column generation of an algorithm optimizes over state variables, and that explodes in size, right? So the current commercial solvers are unfortunately unable to handle that, and we realize we have to simplify or accelerate our solution approach. And that brings me to the third and last components of this algorithm, which is trying to use deep learning models in order to accelerate these mathematical models. And we do that in three primary steps. First of all, we have to generate some synthetic data for our deep learning model so we can train it, right? A fully connected neural network. So what is actually the input and what is the output for the neural network? The input variable here is different patient allocations, right? So we want to make sure for different patient allocations, we have the output value variable, which is actually whether there is a feasible patient allocation, whether that patient allocation is feasible with regard to overtime and the number of beds and nurses they require. So the input here is to randomly generate a diverse set of patient allocations. And the output, for the output, we utilize heuristics in order to compute whether those patient allocations are associated with a feasible solution with no overtime and also effectively they also respect the limited availability of beds and nurses. So once we have the input and output variables, we try to specify the architecture of the neural network, and we train the neural network afterward in order to obtain the weights that we could utilize in the mathematical model. So we linearize the nonlinear structure of neural network, and we incorporate into the mathematical model in order to create a learning-based dynamic programming algorithm, right? So instead of explicitly formulating the mathematical model for this very last constraints, feasibility constraints I mentioned earlier, we try to deploy neural network in order to help us to classify feasible and infeasible solutions, right? That reduces the number of variables and constraints we require in our model, and it significantly accelerates the model. Okay, so now let's dive into some results. So here we have some box plots comparing the neural network and performance of logistic regression to justify the use of more complicated neural network. On the y-axis, you can see the accuracy of the model, and on the x-axis, you can see different instances that we have created. I've actually reported four of the larger ones. You can see for these larger instances, the neural network significantly achieves a better performance, um, which is around the median performance is around 95% accuracy. And also we can see that in terms of, we also saw that analyzing the area under the curve graph, we saw that the neural network performs even better, performs better in that respect as well. So now that we know that neural network is necessary for this particular problem, let's actually do some policy assessment, right? So we have built this a fancy model that we think it works pretty well, but let's actually do some assessment against some alternative approaches, right? To see whether it really outperforms them, whether it was actually justified to create this new model. So, first of all, we actually considered a few benchmark policies from the literature. I'm not going to go into detail for them, but one of the benchmark policies we considered is myopic policy. So, myopic policy is effectively it's just not considering the future cost. It's blind to the future cost and it's greedy because it just tries to optimize the immediate cost, right? What is happening right now, it's just like we're going to only optimize the performance metric of today. I'm not going to care about tomorrow. So comparing against myopic policy, our approximate optimal policy achieves better results across all of different performance metrics, including wait time threshold, deferrals, emergency department utilization, and a patient transfer. And it's also able to schedule 25% more patients on time, which is quite significant, right? Also, the other analysis we have done, we try to realize why are policies outperforming benchmark policies? Like, what is the reason contributing to that issue, right? So that's actually a pretty important thing that could actually help booking clerks, even without this algorithm, in order to more intelligently schedule their patients. So analyzing our approximate optimal policy, we realized that our approximate optimal policy tries to extend the booking horizon only for the highest priority patients. So allowing them to schedule them even after their booking horizon, right? So being ready to pay some wait time penalty, but be able to schedule those patients only for the highest priority patient. The second thing we realize is that the approximate optimal policy restricts the capacity utilized by lower priority patients. Lower priority patients, they have a smaller penalty for transfer, smaller penalty for wait time, smaller penalty for deferral. At the same time, they have a longer booking horizon, right? So if we are not limiting them, it's highly likely that they're going to utilize the capacity in the future since they have a longer booking horizon. So for the future higher priority patients, when they arrive, we already have utilized the future capacity for lower priority patients, so we cannot schedule them. So we realize that our approximate optimal policy restricts the capacity used for lower priority patients, right? So let's say we cannot utilize only 30% of capacity for lower priority patients. So in that case, it reserves future capacity for higher priority patients. And it prevents a lot of highly transfer costs, wait time penalties, deferral penalties, etc. Once we incorporated these two simple mechanisms into our optimization algorithms, into alternative mechanisms, we realized that incorporating these improves benchmark policy significantly, and it, in fact, closes the optimality gap to within 5%. All right, so what are some key takeaways here? We hybridized infinite horizon approximate dynamic programming and deep learning to study multi-appointment ambulatory care scheduling with heterogeneous resources. We demonstrated that our approach outperforms benchmark policies when we also propose easy to implement scheduling policies. Um, assessing a case study from Ottawa Hospital, we've been able to show that our approach has the potential to improve patient wait times, It can improve access and ultimately patient outcomes as well. All right. Thank you very much for listening to this talk. Please let me know if you have any questions, any ideas, any suggestions for me.